to the Make a Mental Note podcast, where mental health professionals share information and perspectives that illuminate, educate, and is worthy of a mental note. And now your host, Chris Quarto.
Hi, everyone, and welcome again to the Make a Mental Note podcast. I'm your host, Chris Quarto. Well, once again, I wanted to remind you that the Make a Mental Note podcast series is coming to an end, and it's going to be replaced by a new series called Private Practice Journeys. So if you're interested in starting or expanding a private practice, then this is for you. Okay, today's guest on the Make a Mental Note podcast is Susan Noonan, who's going to be talking about depression. So here's Susan. Hi, everyone. This is Chris Quarto, and welcome again to the Make a Mental Note podcast. Today, I'm joined by Dr. Susan Noonan, who is a physician, a certified peer specialist, and consultant at McLean Hospital, and author of the book, When Someone You Know Has Depression. And Dr. Noonan, thank you very much for joining us on the podcast.
Well, Chris, thank you very much for having me. I'm pleased to be here today.
Oh, that's fantastic. And I wanted to ask you a little bit about McLean Hospital. You're located in the Boston area. Is that affiliated with Harvard?
Yes, it is. It's a psychiatric hospital specifically, and it's just outside of the city in a town called Belmont.
Okay. Well, what I like to do when I have guests come on is to tell the mental note-taking audience a little bit about themselves and what they do for a living. So why don't we start off there, Susan?
Okay. Well, I bridge that space between recipient and provider of healthcare services. I have a pretty unique perspective as a long-term patient, the author of 2 books on managing depression with a companion blog on my own website, as well as Psychology Today and the Huffington Post. Mm-hmm. I'm a certified peer specialist, as you mentioned, and I'm a physician. As a physician who has treated, supported, and educated those living with and caring for somebody who has a mood disorder, and as someone who has experienced personally living with depression, I have firsthand knowledge of what's most helpful that's backed by evidence-based medical information. I graduated from Mount Holyoke College, Tufts School of Medicine, and the Harvard School of Public Health, all in New England. And I began my practice in emergency medicine, but now focus solely on folks with mental health issues. And I work as a consultant, as you mentioned.
Okay. That's wonderful. So you actually have a unique perspective, I guess, having been somebody who's dealt with depression themselves, along with somebody who actually helps people who have those types of issues. And I'm kind of interested, just how did you get interested in doing this type of work? Because you said that you did emergency medicine at first, but you made this transition. So tell us a little bit about your story about how you got interested in the field of mental health, Susan.
Well, since grade school, I always knew I was going to be a physician, but I became a mental health kind of expert by experience when depression affected several members of my family and then myself. It seemed to me to make the most sense to share what I learned about the illness with other people, kind of as a way of giving back. Mm-hmm. So I took all of my notes where I sat through seminars and educational sessions and started to write. And my primary goal in writing is to bring depression management strategies to the many people who just don't have access to mental health educational programs, or they don't have adequate mental health care, or the opportunity to learn these skills in any other way.
Mm-hmm. That's interesting. So you grew up in a family with family members that had depression, and you've had this yourself. Do you think that was one of the major things that kind of got you into this field and interested in helping people with depression?
I do, but it's interesting because my depression started as a teenager and was on and off for many years, but it went untreated until I reached the age of about 45, when I had several major losses and started to reach perimenopause, where your hormones kind of take a dive.
Sure.
And it just was never, that was just the way it was done in my family. We just never spoke of it. So even though several aunts and a parent and a family friend of ours all suffered from the illness, we just never spoke of it. It was just not done. So it was very interesting because the longer depression goes untreated and the more episodes a person has, the more difficult it is to treat. And then of course it adds to the stigma that, carries through, that we're all trying to confront even in this decade.
Yeah, and I heard you say that even in your family that it wasn't something that you spoke about. And I think that that's probably similar to what a lot of people experience, even in our mental note-taking audience. I'm sure that there are people who are listening to this right now and thinking to themselves, yep, that's the same thing that happened in our family too. And there has been for many years a stigma associated with mental illness. I think we're finally starting to move in the direction of looking at this as a health condition, much like any other health condition, whether it's diabetes or whatever the case is. That's something in need of treatment, and hopefully we're starting to move beyond that stigma. Do you think that that's starting to happen, Susan? Have you kind of seen that yourself in your experience?
I think we're beginning to. I think it's a generational thing. I think I see teenagers and people in their young 20s, perhaps, who have had the experience of speaking about it in their school educational programs and feel comfortable speaking about it with each other, and feel comfortable approaching a school counselor or a friend to say, hey, I think you need some help. But in later generations, and in particularly the elderly generations, it's just something that is still not achieved.
Right.
There is a group of individuals in the middle-aged professional workforce who are still in fear of job loss if their colleagues or their supervisor at work were to find out that they needed to take time off to see a therapist or a psychiatrist. They might be considered to be less than optimally functioning, particularly if they held a job with some responsibility for other people or a certain degree of responsibility. So they fear that.
Sure.
And so they're afraid to speak up and to say anything to anybody. So it depends, I think, on where you are in life. But it's beginning to happen. I think it's just a slow process.
Yeah, I agree with that, and I like the fact that you mentioned that there seems to be a real risk in people disclosing things about their mental health, because it could lead to job loss. It could lead to unfortunately loss of friendships, whatever the case is, and it's really too bad that it has to be that way. I kind of wonder if you could kind of share with the audience a little bit about what depression is, because I think there are a lot of myths out there about what it is. Like, why don't you just pull yourself up by your bootstraps? And there's all this kind of stuff out there about depression. I don't think a lot of people truly understand how debilitating this is. So why don't you share a little bit about what depression is and what makes it such a difficult thing to go through in life if one has depression?
Well, depression is a biologically based illness. It affects both the mind and the body. It affects our thoughts, our feelings, our behaviors, our actions, and the everyday lives of many, many people.
Mm-hmm.
So it could affect the things we do, it affects our sleep, our appetite, our interest in doing things that we might have had a prior interest in doing. It affects our relationships with other people. We may have a sense of despair, of hopelessness, of worthlessness, feeling that we're not an accomplished or worthwhile human being. There may be suicidal thoughts that come along with that. That is a very dangerous position to be put in.
Mm-hmm.
Researchers have begun to show us that there are genes associated with depression, which when you combine with a stressful life event can lead to an episode of depression. So that means that in some cases we inherit this illness from our families. And that should help us decrease this stigma, this sense of burden or shame that some people carry about the illness. It is just as much of an illness as someone who has asthma or diabetes or high blood pressure.
Mm-hmm. So this, the inherited aspect of this sort of combines with stressful life experiences, I suppose, and I think that there's a phrase for this. I think the model is called Diathesis-stress model, and so there's this combination that they kind of go together. And I wonder, Susan, in your experience, when you've worked with people, what types of stressful life experiences can precipitate a depressive episode?
Well, there could be all kinds of things that are both positive or negative. It could be a change in a job or the loss of a job. It could be moving to a new home. It could be a new relationship or a loss of a relationship. It could be the birth of a baby. It could be anything new that changes your routine significantly, that adds to your daily activity level. Any kind, and it could be surprising. It could be marriage, divorce, the death of someone in your family who you love. Of course, those you might think are common things, but the ones that I preceded that with are things that might surprise somebody.
So all those things that you just mentioned, the things that they have in common is that they all involve change, don't they? Of some sort.
Yes, they do.
And in some
Correct.
cases, those changes are quite significant. The death of a loved one, a divorce, even moving somewhere. You think of teenagers who have to move from the high school they were at to another high school in another town, and the loss of friendships and relationships and all those things. So you could see why for some people these are really difficult things that they have to contend with. But isn't it true that some people who experience these changes, the loss, death, whatever the case is, they don't experience depressive episodes. Some experience depressive episodes, but some don't. Do you know why that is, Susan? Any guesses as to why some people will go into a depressive state when they experience a change like this and others don't?
Well, that's a very, very good question. And that's the combination of the genes and the environment.
Okay.
You need to have the genetic predisposition. As I said, researchers have identified certain genes that some people may have that predispose a person to become more vulnerable when they have a stressful life event, to then become more predisposed to an episode of depression. That's kind of a more simplified way of the very long scientific explanation for it, but that's kind of the way. If someone is not predisposed to it, they may be more resilient to moving their home or changing schools or a job position or something like that.
So I guess
just because somebody has a gene that predisposes them to an episode of depression does not guarantee that they will have depression.
I see.
It's not a given. They also need the combination of some stressful life event at a particular moment in their vulnerable period of their brain developing to have this episode of depression.
Sure. So I guess that there can be a lot of differences that way. And I suppose as I think about this and hear you talk about this, for physicians, for mental health professionals who are helping people like this, I suppose that it's very important to get a family history, isn't it, to find out if there's been any episodes of depression in the past in one's family.
Yes, that is very helpful to know because that can put it in context and help the person with the history, just as with other medical problems where family history may be important. It's important to also to know what's going on in the family environment, what stressors there may be within the family for the physician to know. And that's really sometimes difficult because when you go for your annual physical exam, the physician may be limited in time by insurance constraints to not have an hour and a half to sit down and talk to you about all of these things. So you have to kind of be, efficient about it. But those are very important things to bring up and be aware of.
And I suppose too that a client has to be willing to even bring up the topic to their physician or to a mental health professional. Like, hey, I've been having this issue, and I'm not sure what's going on. I'm not sure what to do about it. And this, I think, is where perhaps that stigma, the shame or the guilt, whatever it is, that can rear its ugly head again.
Yes, a lot of people might not recognize that what they're experiencing is a symptom or a sign of something that's significant, but they may also be in denial and may not want to admit it to themselves or to their physician, or their spouse or parent or other family member. So recognizing the signs and being willing to speak up about them is a very important thing.
Exactly. Well, I'm kind of interested in your recipe for success, Susan. If you look at people that you've worked with who come in to see you at point A, where they're having these depressive symptoms, and then you work with them and they get to the point of point B, where their symptoms are no longer at the same level of intensity, and they seem to be able to go on and function okay in their daily lives. What is that you do to get them from that point A to point B so they can go on and function more effectively in their lives?
Well, what I like to do is help the person to clearly identify what particular problem he or she is really bothered by.
Okay.
And what they're really motivated to work on. And it could be several things, but you can't attack too much at one time. You can't try and fix your whole life all at once because that becomes overwhelming. So I can try to help them narrow it down and focus on helping them take a series of small and realistic steps towards reaching a goal, to identify one or two problems at a time. In order to stay motivated And to do this, it's very helpful for the person to look at the benefits of solving that problem, whatever it might be, a relationship problem, a problem at work, a problem with your child or your parent or your next door neighbor or whatever it might be, a problem within yourself, to look at the benefits of solving that problem and compare that with the cost to them of remaining in the status quo. And let them use that as a motivating tool. Then it's helpful to have them identify and take the small steps to get there, helping them to identify the resources and the people they need to help them succeed, because you can't do it alone. Everybody needs to recruit some assistance along the way.
So what you're saying here, cost-benefit analysis, taking small steps in social support. I guess those are three critical parts of what you do in helping clients. And I also heard you say at the very beginning of this episode, you had mentioned the phrase evidence-based. And maybe you can share with the audience what you mean by this and perhaps how this figures into the treatment equation.
Well, I try and offer individuals as much as possible what's available out there as far as clinical evidence to back up or support whatever statements or recommendations that I might make.
Okay.
We don't have in science the answers to everything, but we do know that certain things do help and certain things do work. And we have some studies out there that would support sleep, for example, getting regular sleep 7 nights a week.
Yes.
And, don't believe the myth that you can catch up on sleep on the weekends, because that doesn't work. Or the benefits of daily exercise or a healthy diet, things like that. And to share with them the rationale and why it works. And when a person has good information, that's reliable information, they're much more prone to believe what you're saying and to stick with the recommendation.
It's interesting because you have said the same thing that a lot of my guests have said about dealing not only with depression but with other mental health issues as well, and that is exercise, diet, proper sleep. I mean, these sound so basic, but they're so important, aren't they?
They are. They're actually the basics of mental health. You add to that keeping a daily routine and structure, because endless hours of empty alone time are not healthy for anyone.
Okay.
And avoiding isolation, keeping up with your social contacts, your friends and family. And those are the basics that one needs to attend to, with some flexibility. You don't have to be rigid about it, of course. But.
So have you had the experience, and I'm sure you have, of you're working with somebody with depression and you're doing these things that you're talking about, and perhaps they're taking antidepressant medication, but it just doesn't seem like they're responding and doing as well as you would like them to get to that point B. Then what do you do? What do you do in those cases of treatment-resistant depression?
Treatment-resistant depression is very difficult. I am not in the practice of prescribing medications for depression. So I leave that to others who are far more experienced in that than I. And there are many reasons for a person who has what's considered treatment-resistant depression. It may be that they're not on the appropriate dose of the medication or for a long enough period of time to determine whether it's going to work. And it may be because they don't tolerate that medication well. They may be having side effects to it. There are a number of different reasons for that. Mm-hmm. So that's something that needs to be teased out. It may not. There are many different types of antidepressants, and there are many different flavors of depression. Some people sleep too much. Some people sleep too little. Some people have agitation and irritability. Some people have different pictures. There are 9 basic symptoms, and you need to have 5 of them to make the diagnosis of depression. So there could be a spectrum of symptoms that a person would have, and you can choose different antidepressants based upon how the person is presenting. Mm-hmm. So it may be that they're not on the best choice of antidepressant for that particular person. They may need to switch to something else or have 2 medications, one as augmentation.
I see.
It may be that their depression is not accurately diagnosed, particularly in an elderly person. An elderly person may appear depressed. Sometimes it may be because they're on 15 different medications for their heart disease and high blood pressure and arthritis, and you take away some of those, and all of a sudden their head clears, and they're not appearing depressed anymore. And that leaves a smaller number of people who are truly treatment resistant. Mm-hmm. And there are many things that can be done for people in those categories. It's not something that you give up on. There are a number of different out-of-the-box treatments. There's ketamine treatment. There's transcranial magnetic therapy treatment if it's available in your area. There are a number of different other medications or combination of medications that can be used. And so I would just defer to the psychopharmacologist to use that, all the tools at their disposal to be able to optimize the person's treatment at that end. Mm-hmm. On my end, I would help them in the following way. If they are ready for change, a person who's ready for change has to be so dissatisfied with an area of their life that they want to change it. Right. They have to accept that they have an illness and that there are ways to manage it. And then we just do it in small steps. I can guide them on that, making realistic small steps. Mm-hmm.
So
but working together, it's for a number of people, it's really considered a team approach, not with a team of providers, not just one.
I see. So as I was listening to you talk about this, in particular, the number of medications that some people take, in addition to getting that history about family, history of family depression, I suppose it's also important to get some information about the medications that people are taking and to find out if perhaps those might be either causing the symptoms or maybe kind of, contributing to some of the mood issues that a client might have.
Oh, yes, that's very important to know that. It's important to know what medications they're currently on and what medications they might have tried in the past and what response they might have had to those medications in the past. Say they are seeing this doctor for the first time and they don't know all of the history, for example. It might be important to, keep a small notebook or a small list of what medications you've been on and what worked for you and what didn't work for you. Mm-hmm. and share that with your physician.
Yeah. Susan, are there any other challenges? We've been talking a little bit about the treatment-resistant depression and some of the medication issues. Are there any other challenges that you found in your work with people who have depression? What are some of the other challenges that you've run across, and how do you deal with some of those challenges?
Well, one challenge are some people who are just not open to suggestions or possibilities that could be helpful.
Okay.
They might know of them, but they don't believe it's going to be helpful for them.
Mm-hmm.
Could be helpful for somebody else, but not for me.
Right.
I'm, too sick or too above that. And that's a difficult thing to try and work with somebody. But another thing that's difficult to work with is someone who's very impatient with the process in the time frame that's required.
Mm-hmm.
Someone who wants immediate benefits from treatment without being willing to do some work to get there.
Mm-hmm.
We're so used to understanding that if we have a sore throat or a strep throat, we can take antibiotic for 5 or 7 days and we get better.
Right.
And for a mental illness, we have two things to contend with. One, it takes weeks, if not several months, before you begin to feel like yourself again.
Mm-hmm.
And secondly, you have to contend with the fact that this is a recurring illness, that you may have relapses and recurrences. And that's not something that's easy for most people to deal with, particularly at the beginning.
Mm.
That, they have to, I have to be on medication for the rest of my life?
Mm-hmm.
What are you talking about? And, data is out there that if somebody has one episode of depression, they have a 60% chance of having a second. If they have 2 episodes, they'll have a 70% chance of having a third at some point in their life. And if they have 3, they're going to have a 90% chance of having, 4 or more episodes of depression at some point in their life.
Wow.
And that's really hard for people to accept.
Yeah.
Of course, you don't throw that data at them at the beginning, but it is something that they need to grapple with in order to comply with sticking with, taking medications and psychotherapy, because the combination of two is really, your best advantage for the better outcome.
Right. Well, I think that, what you first said, it makes sense to me that a person might say, well, this will never work for me. This just might work for other people, but not for me. I would think that would be part and parcel to what they're dealing with, depression. I think that that's part of the hopelessness and thinking that, nothing ever goes right for me, and just sort of that, the black cloud constantly over their head. And then I think for what you mentioned for the impatience, I think that, in our culture nowadays, we're kind of used to getting everything instantly, aren't we? That we want instant gratification, and it's hard to wait. And, for something like depression, it takes time for a person to improve.
Oh, yes. And that is only getting worse over the years as everything comes to us so much more quickly.
Yeah.
Where, at odds, if our, internet access doesn't come up within microseconds as opposed to 5 seconds.
That's right.
Or, the fact that 10 or 15 years ago, we didn't even have access to it. And now we complain if it doesn't come up quickly enough.
It's amazing. So it's amazing.
It's a whole cultural shift.
It is.
It's what we're getting used to.
Yeah. Well, Susan, this last part of the interview is what I refer to as make a mental note. And I like my guests to talk a little bit about, some tips, words of wisdom that they could share with the audience, something that the audience can make a mental note of in terms of improving their own mental wellness. Do you have any tips or words of advice to share with the audience along those lines?
Well, there's one very common and helpful phrase that I've heard repeatedly that's been helpful to me and others, and that is action precedes motivation. And this means that when you are feeling absolutely awful and down and tired and ill, and you don't want to do anything, particularly the things that you know deep down inside that you will make you feel a little better, that you don't wait to want to do it or wait to feel motivated to do it. You just make your best effort to go ahead and get started anyway. And eventually, the desire to do it will follow. Eventually, you'll see that you'll feel some inspiration to do it. You'll feel that it will actually make a difference in making you feel a little bit better. And this is particularly important in depression, where one of the key common characteristics is a loss of interest or pleasure in previous activities and people. So it kind of targets that one main symptom that many people do have. So action precedes motivation. It's easy to remember. And
yes.
It's kind of the mantra of a lot of therapy groups I've been at, and it seems to be easy to remember.
I hadn't heard that one for years. It's really interesting though, because it's almost like all of us are kind of motivated to do stuff and we go out and do it. But with depression, it's the opposite, where there is no motivation and you have to do something first to kind of get the gears moving, so to speak. And that's sort of this whole idea of action precedes motivation. And it's really nice to hear you say that, and for the audience to listen to that and to remember that. And that's really great words of wisdom there. Well,
yeah,
Susan,
and I can tell you it does work.
Great. Well, if a potential client or somebody is interested in getting help from you, or the book that you've written, if they would like to read your book, share with the audience how they could either get a hold of you or get a hold of your book.
Well, I have a website, and I have email and contact information on my website, which is SusanNoonanMD.com.
All right.
And there are links to actually both of my books. The first one is Managing Your Depression, what you can do to feel better. And the second is Someone You Know Has Depression, or When Someone You Know Has Depression. And those are available on Amazon.com or Barnes & Noble or perhaps your local bookstore. But I have an email on my website, and people can contact me that way. And I blog on that as well, so they can read my current thoughts. So
Wonderful.
I would be pleased to hear from folks.
Oh, that's great. Yeah, and I really appreciate you coming on the podcast today, Susan. This has been a really interesting to talk about depression, because this is such a common illness for people, and to have somebody like you come here and talk about it and give people not only words of wisdom but hope that this is something that can be successfully treated and dealt with. It's really nice to have somebody of your stature come on here on the podcast. So I really appreciate your time today.
Well, thank you very much. It's been my pleasure.
Okay, thanks. All right, I appreciate Susan coming on the Make a Mental Note podcast today. And here's my mental notes takeaway. Depression is an illness that's oftentimes based on a genetic predisposition to exhibit the disorder. And it's usually precipitated by stressful life events. Now, here's my question. Are negative stressors or life events the only things that can trigger depression? Well, the answer is no. Susan said that both positive and negative stressors can precipitate a depressive episode. She had said things like changes or a loss of a job, maybe moving to a new home, getting involved in a relationship, or getting married can be very positive things, but of course losing a relationship can be just as bad. The birth of a baby is usually a very positive experience, but very stressful. So events that bring about change seem to set the stage for depressive episodes for many people. Okay, check out my website, chrisquarto.com, for the show notes of today's podcast episode. I'd like to start to make some continuing education credits available to people who listen to these podcast episodes. I'm hoping to get this approved through NBCC, in particular for counselors, but others also who want to get credits, probably one CEU or continuing education credit per podcast episode, and I'm going to get that in line pretty quickly here. So keep your eyes open for that. We're moving toward the end, like I said before, of the Make a Mental Note podcast series, and my new one called Private Practice Journeys is about to start, so keep an eye out for that as well, especially if you're interested in starting or expanding a private practice. Well, thanks for listening, and have a great rest of the week.